Mm. Mm. Oh. What do I want to do? Hello, Mauricio, you there? Hello? Testing.
Dr. Brennan, good morning. Yes,
Can
I'm
you
here.
hear me? Can you hear me okay?
Yeah, I can hear you. I can hear you.
Good, yeah, it might come up. Oh, yeah, I'm glad you're here. You know, Mauricio, normally I'd have you moderate. Now, do you know these guys?
Dr. Ive and Dr.
Dio
Well,
Pujari and Dr. Goel. You know, let me introduce them because I kind of know these guys.
okay. I think
Okay.
I've talked to them in a lounge or two, maybe.
Oh, okay. Okay, yeah, we're gonna have that hopefully, so you guys can meet. You know, they're great guys. The two Goel and Dio Pujari, really good guys, and they're good. They're good to know. So you'll meet them there most likely. There's Stephanie.
Okay.
Wow, Stephanie's here. Great.
Hi, Doctor. Good morning. Hi,
Hey, good
Mauricio. How
morning.
are you?
What a surprise. Great.
Hola,
Yeah,
hola.
sorry,
Yep.
Doctor. I've been sick. I'm really sick.
From Bolivia and Paraguay. We're starting in 12 minutes. Hey, Victor's here. Victor will tell you about his, we had a birthday party on the Zoom for a neurosurgeon from Argentina.
Hello, how are you, John?
Hey, Victor, did you like that birthday party?
Yeah, was really good. It was really nice.
I was surprised because he sent me that Zoom, I don't know what they call a Zoom birthday,
Yes.
but this neurosurgeon from Buenos Aires, Rolando, I think you guys know him.
to-
He sent me an invitation, come to my birthday on Zoom. And he had friends from all over the place. And Victor came and sang Barrera. And there was a guy that played the guitar from, was he from Argentina? I think the guitar player was related to Orlando. And yeah, it was good.
Yes, the party had many friends of Rolando.
Yeah, all over the place.
Yes,
So
from Spain. I think from Portugal, Colombia, Ecuador, and somebody from Central America. Yes, was really fantastic.
yeah, and I was surprised. I was just saying, I got the invitation. I said, well, when I got there, it was great. I think a lot of those people are his patients, his people he's
Yes,
treated, not
yes,
just family.
yes.
Good morning. The king is here.
My dear John, my
Hi.
dear John.
How you doing, Atul?
Very good, very good. You look fit and fine and fresh.
Oh, it's nice
John.
to be here. It's a pleasure to be here today. To
Yeah,
bring everybody together. There's Abby. How you doing, Abby?
Hello, Atul Gol. How are you?
Hi, Victor. What is the
I,
news?
I agree with John Bennett. You are the neurosurgery king.
Okay.
The Zoom. He found the place in Zoom. You know, Atul, I'm going to do this for the rest of my life. I found something I really like. And I think doctors, when they retire, may look to it.
Avidia, Avida, nice to see you.
Hello, Dr. Victor. Nice to see you. Happy New Year.
Yes, Happy New Year.
Okay. There's Bayam Batson. Are you there? She's a resident from Mongolia. She said there's 30. Hello, Bayam Batson. Are you there? Okay. 30 neurosurgeons in Mongolia. Do you know how you're going to have it structured at all?
Yeah. What's that?
How are you guys going to structure it? Because I kind of left it up to you and Abby.
Let's see, what we have decided is we are going to give 3 lectures.
Okay.
First by me, then by Dev Pujari, and then by Aip.
Okay.
And then we are going to have 2 guest speakers. And then we'll see how to handle the whole story.
Okay. Okay. Maybe we can have the lounge at the end. Right. Because we can't do it like we're doing a presentation. We can't do another Zoom too. So we'll just put the lounge at the end. Okay, Mauricio and
Okay, good morning, Dr. Azul. Good morning, Dr. Sa.
Morning,
It's okay.
morning.
yeah, Mauricio is from Paraguay. Paraguay.
Yeah, I'm a med student here in South America. Second year medical student.
Yeah, and Mauricio's associate, Stephanie. Hello, Stephanie. Your camera's not on today?
Hi, doctor. Sorry, I've been really sick, but I tried to get in here because I knew that Dr. Goel and Dr. Victor Hugo and Dr. Abby were going to be here. So I'm from Bolivia. I'm very glad to be here and to have the opportunity to hear you all. Thank you.
Stephanie's very active. Does anybody else, we have a few minutes, anybody else want to introduce themselves to Dr. Goel and Victor? And I think we have a lot of Indian neurosurgery residents here today so far.
You know what, John, in India, this COVID thing has become quite, virulent. And many of the doctors have been taken into grip. So that is another issue here.
It's becoming more virulent. Here, it's
Yeah.
not virulent. It's not.
It is not virulent, but it is, widespread. Many people are getting affected, not much.
Yeah.
Not much intensity, but it is quite a number.
Yeah, here, same here. It's taxing the hospitals. Some people are admitted, but it's not many intubations. Not like the other COVID, I guess. But the same thing, your hospital's full, right?
Not exactly full, but because they are not admitting, many of these fellows are not very symptomatic.
So
they have
Yuha's
been-
here. Well, not symptomatic, huh?
Yeah. Yuha is there? I don't see
Yeah,
him.
we got him out. We got him out. Everybody will be happy to see him. And Mauricio, and you got to meet Yuha. I hope we can hang. Come in here. You may just want to. You can stay in the panel and kind of watch and not participate. I don't know what he wants to do. So.
Here is the same, Dr. Atul. Here is the same in Mexico. The Omicron cases are increasing. So there is a recommendation that a simple grip, that a simple influence should be scanned as if it was COVID or Omicron. So it's increasing also. but not as strong like COVID.
That's right. That's right.
Yeah. Have you been vaccinated, Victor?
Excuse me.
Have you been
Sorry.
vaccinated? Vaccinated? Have you
Yeah,
been-
yeah. All the people in Mexico is vaccinated.
Oh, good. Good.
All the people, yes, yes.
Good. So
Some with one, another more with two, and another three times.
right. Same here with the booster. And there's a pill. Are they prescribing the pill now in hospitals, Atul? The pill for COVID?
No, I don't know. I don't think it is
No,
in
no, it's
India.
not.
At least.
It's not available. I don't know
No.
if it's done here either. I don't know. But I think Pfizer, it's available. You can write a prescription for it. And it's supposed to be pretty effective, like 80 to 85% effective. Pretty effective.
Juha Hernesniemi is here.
Yes, I don't know if he wants to come in. I'm trying to get him in here, but he may just want to watch anonymously. Now that we announced he's here.
Takashi Kon.
Yeah, Takashi, welcome Takashi. Good morning.
And Happy New Year.
Happy New Year
I'm
to
from
you, too.
Tokyo, Japan. I'm Takashi Kon.
Very good. Welcome.
Takashi, Happy New Year to you and very
Happy New
much
Year.
best
Thanks,
wishes
Mr.
to
Goel.
you.
Nice to meet you again. Hopefully, Omicron is increasing in Tokyo, but not severe case.
Same in Mexico, same in Mumbai.
Hmm.
So, okay, Atul, you ready?
Yeah, I'm ready. I'm just waiting for Dr. Devpujari is in.
Oh, okay. Oh, there he is. He just got here.
Nice to see you, Takashi. Very nice to see you. Happy New Year.
Happy New Year, Hugo Perez.
Did you get in okay,
Sorry.
Dr. Pujari?
Audio and video.
Oh,
Great.
there you go. How you doing?
Okay.
Nice to be with you guys. I'm fine, John. Thank you. Thanks for the invitation. Looking forward.
Your conference went well yesterday, I think.
Yes. That was good. It just went on a bit too long.
Yeah, it was. Yeah, it was. The number I couldn't give you an exact number, but they were higher than usual. They were
Okay.
triple what the other days were for on YouTube, but they don't give numbers, just relative compared to others.
Oh, nice. You could. I mean, more people could use it. Is always better. Yeah.
Yeah. Do you want to adjust your camera? There you go. Adjust the camera. Okay, you ready to start? Is Ipe coming? You want to wait for Ipe, or is Ipe coming, or?
Is Ipe already with us?
He's not here now. Let me just check real quick. If hold on the fort, Abby.
Hi, Abida.
Hello, sir. Happy New Year.
Thanks.
Hello, Dr. Devpujari. This is Victor from Mexico.
Yes. Dr. Hugo Perez. Nice to see you.
Nice to see you too.
Abida, you start the show now. I think let's begin. Okay.
Yes.
Okay. Should we wait for Ipe?
John, let's begin.
Have you
Okay.
pinged him, or should
Yeah,
I?
I just did.
Okay.
Wait a minute.
We have some people with us already, I think. Do you have any idea, Atul, if I've managed to speak to a couple of people he was
No, I
sharing?
couldn't connect. I couldn't connect with him, but I think let's begin the show now, Shekhar. Okay?
Great.
Yeah,
Yeah.
okay, okay, very good. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning, this is Dr. John Bennett from Miami Beach, home of Neurosurgical TV. It gives me great honor to start the series of India Neurosurgery Grand Rounds with 3 pillars of education, all of them dedicated to neurosurgery education. And I'd like to start off with today's talk is being given by Dr. Atul Goel. I'll have to tell you his background. Just say Atul. Everybody knows who you're talking about. So, okay, Atul, you're ready to start.
Okay. Abida, go ahead.
So welcome everybody to this grand opening of India Grand Rounds. And to begin the season, we have none other than Professor Atul Goel. And as you all know him as the king of Zoom. And to let you know that he's the king of pituitary tumor surgeries also, with an experience of more than 5,000 pituitary tumors. He has his own classification of giant pituitary tumors, his anatomical understanding of diaphragma sellae and their relation to pituitary tumors. And all this will be now revealed in his talk. And sir, I welcome you. Please begin.
So thank you very much, John, for organizing this for India and for the world. And needless to say that I'm extremely honored to present this in John Bennett's show. And also there is no hesitation to say, and Victor will agree, that John has been instrumental in taking the message of neurosurgery in the nook and corner of the world to every young and senior neurosurgeon of the world. And he has delivered this message free for all. And that is the beauty. Here, you don't have to be rich to go to a particular conference. You don't have to be affluent to go to a particular conference. You sit down at your own house and receive the information. Whoever gets the information and uses that information will be the winner. So that beauty, I think the generations of neurosurgeons will remember the contribution of John Bennett in this. And I personally acknowledge this contribution. John, thank you. So I'm going to take you to the world of pituitary tumors. Pituitary tumor is indeed one of the most fantastic neurosurgical subjects. It is the most rewarding subject for a neurosurgeon. You do a good surgery, you give results instantly. In the post-operative period, you find a different human being. You find a person with different vision and a better vision. You find a person who has changed his face, changed his weight in the immediate post-operative period. You do a bad surgery, there is a potential to harm him badly, harm the person and maybe demolish him. So it depends on how you understand pituitary tumors, how you treat pituitary tumors, your experience in handling the tumors, your experience in demolishing the tumor, how you remove, how you understand the anatomy of the whole area, and then you pursue your dissection. And I have been giving these lectures for some time on the forum of John, and many of you have heard me, but I like to give you again this message, which is so important and so crucial for every neurosurgeon to understand what is pituitary tumor, where is pituitary tumor located in relationship to the cavernous sinus, in relationship to the sphenoid sinus, in relationship to the carotid artery, to the chiasma, how some tumors go and enter into the confines of cavernous sinus, what is the difference in the medial wall of the cavernous sinus which makes the pituitary tumor invade so easily into the cavernous sinus, why there are some tumors which are intracavernous and do not come out into the sella. So these questions may never be answered by human beings, But we have to understand when the question of pituitary tumor comes that this medial wall is selective. Some tumors it let go inside, some tumors it obstruct despite the size. What is the nature of diaphragm cell is unique. Why some tumors enter into cavernous sinus, why some do not enter is a difficult question to answer. But let me see if I can answer some of these questions and re-emphasize and reinforce the message of pituitary tumor, which I have given on several platforms earlier, on Zoom platforms in particular. So sella is a saddle of horse. It is a bony compartment. It is pituitary gland is covered partially, you see, partially by the diaphragm celli, and there is a space for the stalk. So this opening in the diaphragm celli is one of the most fantastic openings in the whole body, which is so selective, and which is the issue which I'm going to talk to you. Why this opening is not amenable for all pituitary tumors. Pituitary tumors do not come out of this opening, and this is my concept. And this concept has huge implications in the surgery of these tumors. And many of these facts I have written in this article of mine, and I hope some of you can read these articles. So this is the exposure from the nasal view, endoscopic or non-endoscopic. What is important is not how you expose, but the question is what you know about this exposure, about the stalk, about the pituitary gland. Just hold on for a second. Let me. Sorry for that brief interruption. So you see the anatomy, beautiful anatomy by Sudeep Jawar. So as far as the tumors are concerned, I have written several articles on my philosophy of relationship of the growing tumor, how the tumor grows, and what are the relationships with the dura and with the cavernous sinus, with the carotid artery, with the walls of the dura of the cavernous sinus. So many of these articles are in press, in publication, and I wish that you will find them. And many of these publications are in form of letters to editor because, there is some hesitation in revealing these important facts to the world from my publications. So pituitary tumors are of various kinds. Small pituitary tumors which manifest early in life, as in Cushing's disease, in acromegaly, in hormonally active tumors. These are small tumors, microadenomas. You remove the tumor, you not only give a new face, but a new life to this person, absolutely new life, and to the extent that the person is cured. So, and in case you do not remove this tumor properly, this person will not even live for 6 months or 8 months and will die. So there is a possibility of curing and possibility of leaving this person in a life of misery and ultimate death. And that depends on how you understand these tumors, Cushing disease, acromegaly. In short, you see, I don't want to talk too much on these tumors. In short, Cushing disease, there is a small tumor, microadenoma. Current concept is, and very well understood now, that you have to remove this tumor in a form of a nodule. You come around, there is a pseudo capsule, and you develop that capsule and remove this tumor in the form of nodule. So en masse removal is a in thing, and that is the way you have to remove this tumor. And various kinds of this kind of nodule, little bit large, little bit small. but Cushing disease, I have done around 350 cases of Cushing disease. You give beautiful new life. You cure the person, and you cure the person in more than 75, 80% of cases. And that is a huge number. And if you are not able to, you give them radiation, you give them all kinds of treatment, they hardly respond. Regarding big tumors, you see, when the tumor grows, and this is my subject, which many of you have heard me before, and that is what I'm going to talk about. When this tumor grows, it can take a massive proportion. When it is not hormonally active, it is non-functioning, it can grow in size before being detected. So it can, you see, I would like to show you some of these massive tumors. You see here, some of these tumors which you will find growing in a haphazard, indiscriminate kind of spread. You see this tumor. And then I will discuss after a few of these cases I show that this kind of extension is not haphazard. This kind of extension of giant or growing pituitary tumors is not indiscriminate. Even these kind of massive tumors have a great respect for the mother dura. And this respect can be beautifully exploited by the surgeon. And that the will to exploit, the ability to exploit, and the ability to remove this tumor will depend on the ability to understand the concepts of dura and these tumors. You see this tumor, you will feel that this is a very, and you, not only you, everybody in the, I'm talking of my experience of last 30 years at least, where these tumors were not understood at all. And all of these tumors, you mark my word, all of these tumors were subjected to transcranial surgery. And that was the pattern of treatment for all these large tumors. And many in the world still are doing transcranial surgery for almost all of these tumors. So you see this extension into cavernous sinus and this kind of tumors. There is a method in madness in these tumors, and that is what I'm going to show you and talk to you about in my presentation. So you see these tumors, and many of these tumors look alike, and many of these tumors have a pattern which is similar to each other, and that pattern I'm going to discuss. Many of these tumors go into the nasopharynx, predominantly sphenoid sinus. Even when they go here in the sphenoid sinus, it is not just occupying space. There is a pattern of extension, pattern of involvement. So these giant tumors is a big burden on the human body and a big burden to the surgeon, because these tumors, patients come with visual deficit. You remove the tumor, you give new vision to the patient. On the other hand, you do a partial and incomplete and subtotal kind of resection. These patients do not survive. There can be bleeding in the tumor and these patients die. So let me discuss about the concept. The first concept that we introduced for the first time in the literature, you mind my word, first time in the literature, we introduced this concept that when there is a tumor, pituitary tumor, the sella enlarges and the diaphragm celli is elevated on the dome of the tumor. So the whole tumor is under the diaphragm. It does not come out through the hole in diaphragm. So this concept has completely revolutionized pituitary tumor surgery. The diaphragm celli is elevated. So this is one of the very common pattern of extension. Now you can see clearly in this slide, the sella is enlarged. The sellar dura is intact. The sellar bone is also thinned out or eroded, but it is intact. You will find a thin shell of bone always here. And after you remove the thin shell of bone, there is dura which is stretched. And the dura of the diaphragm celli is elevated by the tumor. So this concept, which we introduced in 1996, has great implications, and that you will realize if you do not have this concept and you feel that this part of the tumor is dumbbell shaped And the diaphragm is only in the middle, and beyond the diaphragm, this tumor is subarachnoid space. You just cannot remove this tumor by transnasal route. You will have to adopt a transcranial route. Even this tumor with multiple nubbins have diaphragm celli intact, and this diaphragm is very difficult to be pierced by the tumor. And the surgeon has a responsibility that he does not pierce the diaphragm during surgery. So diaphragm is intact, the sellar dura is intact, the posterior part of the tumor is intact, the dura is intact. Even when the tumor comes in the sphenoid sinus, the dura of the sella is intact. So these are very statements that you have heard from me several times, but they're so important and so crucial. Many a times I call this grade 1 tumor when the diaphragm is elevated, but the tumor does not enter into the confines of the cavernous sinus. The medial wall of the cavernous sinus does not allow the tumor its entry. So these tumors which are under the diaphragm, not in the cavernous sinus, I call them grade 1 tumor. You see this tumor, when the artery is not completely encircled, it is grade 1. Diaphragm cell is elevated by the tumor. Cavernous sinus is not invaded, grade 1 tumor. So you must remember the fact that the diaphragm cell is elevated. So you come from the nose or you come from transcranial, the diaphragm has to be respected and protected during surgery. You see, it is a beautiful tumor. If your concept is that the diaphragm is only up till here, which was the concept and which is still the concept in the minds of several neurosurgeons all over the world, and you will see recent publications which also mention that this part of the tumor is subarachnoid in location, which is absolutely wrong. The diaphragm of the dura of the diaphragm celli is thinned out and looks like arachnoid, but the consistency and thickness is like arachnoid, but it is not arachnoid, it is dura, the thick layer of dura, which demarcates the tumor from the circle of Willis, from the chiasma. You remove the tumor, the whole diaphragm will come and herniate into your picture. So these are grade 1 tumors. You see this huge tumor, there is no boundary, there is nothing in between. The diaphragm is elevated and the tumor has occupied sellar component, suprasellar component, but infradiaphragmatic. So these are grade 1 tumors, not involving the cavernous sinus. The grade 1 diaphragm cell is elevated. This is another beautiful tumor for your beautiful visual delight. No cavernous sinus involvement. Diaphragm is elevated into multiple domes. The artery is along the dome of the tumor, not inside the confines. This kind of tumor nubbin, there is an intact wall of dura. It is not inside the brain or inside the parenchyma. There is dura, and this dura protects you during surgery. You see this tumor, if your information is that this is subarachnoid and this is having intense relationship with the basilar artery, with the perforators of this region, you just cannot remove it. On the other hand, if you have the information that the dura is going to be intact, these are soft tumors, you remove this tumor, there is quite a beautiful chance that you can remove the whole tumor from the nose. And this is the concept. Whether you use microscope or whether you use endoscope, that is a very minor change of concept. You see this tumor, there is dura. And this concept is now taking ground in the whole world. But this was the introduction that we made. You see, the subfrontal extension was a very classical indication for transcranial route, but dura remains intact. You remove the tumor, and you can remove this tumor in good 15-20 minutes, debulk the tumor, demolish the tumor. Many of these tumors are cystic tumors, There is wall of the dura which covers the tumor. You break the tumor, learn how to remove the tumor from along the wall, learn how to pull the diaphragm into the surgical field if it doesn't fall, know how these tumors will fall, and know how to hold the dura of the diaphragm and pull it into picture. And these nubbins are subdural in location. So this tumor, when it goes in the sphenoid sinus, also has a dural protection, and this has to be, the dura has to be respected. So you see, these tumors are large, all right, aggressive, all right, but they are disciplined, like a very fantastic student of the class, disciplined, respect the teacher, respect the mother, remain under the confines of the dura. So you see, I'm showing you several cases. See how these tumors are respecting the dura, how these tumors are in the form of nubbins in front, above, behind, but confined to a compartment. Now, grade 2 tumors are also very common when the medial wall is transgressed, internal carotid is completely encircled, lateral dural wall can never be transgressed. You remember this. Diaphragm cell is intact. So this configuration is grade 2. Artery of cavernous sinus, internal carotid is encased. Internal carotid is encased, tumor in the cavernous sinus, lateral wall cannot be transgressed, medial wall is transgressed. So medial wall, whether it is dura or not, is a controversial issue. Many articles have been written on this subject. You see, both medial walls have been transgressed. I call it grade 2 pituitary tumor. You see, the lateral wall can be stretched severely. This understanding was never there in the literature, and you must remember and acknowledge this fact that this concept has great relevance to these kind of operations if you have to do. So medial compartment, what is medial compartment, what is medial wall of dura, are the issues which have to be understood very nicely. Some tumors like cavernous hemangioma of cavernous sinus are in cavernous sinus but cannot go into the sella or into the pituitary gland. This is a very important, why some tumors from the cavernous sinus cannot enter the sella, and why some tumors from the sella enter into cavernous sinus. So this relationship of carotid artery with the tumors has great impact on cavernous sinus surgery. Pituitary tumors commonly encase the carotid arteries. Nasopharyngeal tumors, these kind of tumors, meningiomas, encase and squeeze the carotid artery. So tumors involve bilateral carotid, bilateral cavernous, dura is intact, diaphragm is intact. This information about the dura, if you do not have this information, and if you do not agree with this concept, you cannot do these tumors. That is for absolutely. If you do not think that there is a wall of dura or meninges which cover the tumor, you can do endoscope or microscope or whatever scope, you just cannot remove it. So these are the tumors which are having quite a widespread extension, but there is a method in that madness. There is a method or style in that extension. Diaphragm is elevated, dura of the lateral cavernous sinus is stretched, but not transgressed. Now you see this beautiful, which I have shown on several occasions, which is very, very common, not uncommon. You see this elevation of the dura of the roof of cavernous sinus. And if you, whether you acknowledge, I see some papers where this fact is not acknowledged, that we were the first one to say this, that the dura of the roof of cavernous sinus is elevated. This is subdural. Diaphragm is elevated. So when the dura of the cavernous sinus is elevated, roof, this is our grade 3 tumors, and they are a little bit more aggressive form of tumors. You see elevation of the dura of the roof of cavernous sinus, lateral wall is intact, diaphragm cell is intact, elevation of the roof of cavernous sinus, beautifully seen, elevation of diaphragm, elevation of roof of cavernous sinus, involvement of the cavernous sinus. These are very common form of extensions in large or giant pituitary tumors. Understanding these facts is important. Not important, crucial, critical, absolute, mandatory. You see elevation of the dura of the cavernous sinus roof, beautiful. Diaphragm celli, beautiful. Lateral wall, fantastic. Not transgress. You see, this looks like a very strange kind of tumor. They were called it frontal extension, temporal extension. No, these are subdural extensions. These are under the dura. Elevation of diaphragm roof in the form of nubbins. Elevation of roof of cavernous sinus. Elevation of roof of cavernous sinus. Elevation of diaphragm. You see, beautiful extension. This extension is very common pattern of extension. Elevation of diaphragm, elevation of diaphragm, elevation of roof of cavernous sinus, elevation of roof of cavernous sinus. So these are very beautiful extensions. You see elevation of dura of the roof of cavernous sinus. Elevation of diaphragm, elevation of dural roof of cavernous sinus. This extension, if you have to remove, you have to understand. Elevation of roof of cavernous sinus, diaphragm, roof of cavernous sinus. You see, it looks very strange kind of extension, but there is a method in this madness. Elevation of roof, elevation of diaphragm, elevation of roof. Grade 3 tumor is, you see, looks like extension here, but it is in the cavernous sinus, elevation of roof of cavernous sinus. Elevation of, you see, beautiful. You see this extension, this case, the chiasma is being compressed, not by this subdiaphragmatic portion of the tumor, but elevation of the roof of cavernous sinus, this portion is compressing the chiasma and causing visual deficit. So you have to remove this tumor. Of course, these are, this issue is a different issue about when to remove the cavernous sinus portion, when not to remove. You see, this is another elevation of roof of cavernous sinus, elevation of roof of cavernous sinus, elevation of diaphragm. Grade 4 is when the tumor transgresses the diaphragm celli or roof of cavernous sinus and involves the arteries of circle of Willis, encases the arteries of circle of Willis. These are grade 4. I consider them aggressive form of treatment or aggressive form of pituitary tumor or a malignant pituitary tumor. And tumors which do not respect mother dura are, in my estimation, more aggressive form of tumors. You see encasement of basilar artery, encasement of suprasellar carotid artery. These are grade 4 tumors. Now there is some noise, John.
Sorry about that. Got it.
Okay, Shekhar?
Yeah.
Dr. Devpujari? Dr.
Yes.
Devpujari, you want me to
Yes.
continue, or let me just continue for some more time till IPE also joins? Okay?
Okay.
Yeah, IPE is here.
Okay.
IPE is here.
Okay, so just enjoy some of these slides.
Yes,
And be happy about it. IPE.
Yes,
So
I
you
am
see
here. I am
this-
here.
So this is the roof elevation. This is the stretching of the dura. These tumors are soft. Learn the art of demolishing this tumor. Every tumor has to be respected in a different light. You break this tumor, you don't have to coagulate pituitary tumors. You break the tumors, you demolish them. You break the tumor in this direction, respect, turn the microscope, turn the vision. There is no need to have this kind of vision. This tumor will ultimately fall beautifully into your field. The diaphragm should be circumferentially seen into your vision, and that will indicate the radicality of resection. Some tumors involve the clivus. These are rare tumors. But here also I will discuss later in my discussion that there is a method in this kind of madness, this kind of infracellular extension or nasopharyngeal extension. So this is my grading scale. Grade 1 is when the tumor does not involve the cavernous sinus, it elevates the dura of the roof, dura of the diaphragm celli. That is grade 1. Grade 2 is when it goes into the cavernous sinus, it elevates the diaphragm celli. That is grade 2. Grade 3 is when it elevates the dural roof of the cavernous sinus. It is grade 3. And grade 4 is when it transgresses the diaphragm celli and encases the arteries of circle of Willis. That is grade 4. And that is my classification. And I have no hesitation to state that this classification has great impact on the understanding. I am giving this lecture for last 25 years. And many of you have heard me repeatedly, and many of you know my slides because I've been talking for 25 years. And there is no question that it has great impact in the changing of the strategy throughout the world on how we deal with pituitary tumors. So grade 1s are very common, grade 2s are also common, grade 3s are also common. You see, not uncommon, elevation of roof of cavernous sinus. This is from my paper. This was published several years ago. Now, this is the uterus. Now, what I want is, Shekhar, Dr. Devpujari,
Yes.
I want you to just go ahead with your presentation, and then I will like to come back and talk and give you some pictures of my surgical cases. Is that okay?
I am okay with, if you want me to start sharing my presentation, I can do that.
You please do that. Then I will bring the same slide up and go further from this point. Okay, Shekhar? Please start your presentation.
You will have to unshare first.
Yes.
Now, do we want any discussion right now, or we just wait?
We will have the discussion after. Now, I have given an overview of pituitary tumors anatomy. Now you talk about surgery, and I can also talk about surgery, and then I will show some more slides, and then we can have discussion. And if we have guest speakers, we will also invite them in the discussion. So you please go ahead, Shekhar, with your presentation.
Okay. Am I visible, guys?
Yes, very much.
Yes.
Great. So first of all, John, I think I echo what Atul said at the beginning of his talk. I think your human service really to the neurosurgical community all over the world is really not only appreciated, it's valued considerably. And I think the pandemic made people aware, though you had started much earlier on this, and we have worked together even earlier. I think the pandemic has brought out the dimensions very clearly to people, and the newer experiments with several programs and their formats are also working very well. So I wish you all the success, and I think it gives us really a very good platform to exchange ideas. And I think I must also congratulate, because he's been a very strong advocate of digital education, and I am really glad to be a part of this program. So Atul has given us a very good overview of the subject with a strong emphasis on what he has tried to say, and I'll just try to give you my perspective on this. So basically, whenever we are trying to deal with a difficult problem, we are looking for, some guidelines. And the guidelines which were given to us by creating various classifications did not clearly talk about the giant tumors to begin with. And you can see that the tumor outside the sella, and the general consensus in neurosurgery is any tumor which is more than 2.5 centimeters is usually called a giant tumor, especially if it is in a restricted space or if it has the skull base. And many of these have implications in terms of should they be observed, should they be treated, what would be their effect on the surrounding structures, etc., etc. Nos brought in the paracellular invasion classification, which also became important for surgical treatment of these patients. And though Atul has some different views on this subject about the medial and the lateral wall of carotid, I think generally we agree that cavernous sinus invasion is a definite consideration whenever we are dealing with these tumors. what I would like to tell you is that initially I started off most people of my generation with the classic skull-base approaches. And this is one of the pituitary tumors I actually treated in early 90s, or I think late 80s, 89 or something, where we did a proper skull-base approach, a bandage flap, and removed this tumor. And I could not find a post-operative MRI, but I could find a CT scan where I thought I have done a reasonable kind of a excision of this patient with a very good improvement in her vision. And some of these tumors, this was a recurrent tumor, and you can see a paracellular extension going beyond the flow void of probably the some important branch. And the main question was that as it was not a strictly midline tumor at that stage, I also used a terional approach, which had become very, very popular. This was again somewhere in 90s, I think, where we use this. And depending on one of the important things which Atul has brought about, but has not probably given so much importance to, is the consistency of the tumor. So one is the spread beyond the blood vessels, and secondly, the consistency. And you will find that if you have a good consistency of the tumor, you can do this. The biggest problem with transcranial approach remains the fact that you are dealing with a tumor which is just beyond the circle of Willis, and all the perforators and important arterial branches are coming in your middle. So unless you have a tumor which is very nicely suckable, or if you have a tumor which you can easily dissect out, it becomes a little difficult problem. Even if the tumor is not very hard, even a sticky tumor can create problems for you because of this fine blood vessels which are stretched all over the tumor. And this very important thing has actually caused a lot of the morbidities associated with transcranial surgery for pituitary tumors. This patient we got away because we could see the stretched perforators and we could save most of them. And though I had heard papers from Jules Hardy, and though he has not made a big sort of point about it, he has written in Canadian Journal of Neurosciences in 1990. But I first heard him, and not only him, I think Dr. Banerjee from AIMS also presented his experience with large pituitary tumors. That time, I think it was some 35 tumors odd, but it was not written up as well as Atul brought it out in his paper in 2004, which probably was the first time it was documented very well that not only giant pituitary tumors form a separate group, but the importance of dura, and the fact that this was probably the explanation why the results of endonasal or transnasal surgery were much better than the transcranial surgery, which was not understood so well. Most people have reported at that time, if you have seen, including the paper which is written by Jules Hardy on this issue, out of some 70 odd cases which he has presented in 1989, there were of the large tumors beyond 2.5 centimeters. He has operated 75% of them by transnasal approach with reasonable results, while he operated on other patients by transcranial approach, and 4 of them developed large hematomas with severe morbidity. We also looked at various other things. Why should a patient, or why some other factors can be also important. One of the things which most of us feel is that the tumor which is becoming dark on T2 weighted images is probably more fibrous, and it is very difficult to remove by transnasal approach. And this was one of the factors which was in our mind when I was dealing with this patient. We usually do a CT angio, and we planned in this patient that we'll do a 2-stage surgery, but the first stage will be probably transcranial because the tumor looks like quite tough, and then we'll plan transphenol surgery as the second. And we did a bifrontal craniotomy, interhemispheric transcallosal transventricular approach, and I have been able to get a reasonable amount of tumor out as I thought. but you can see the post-operative scan shows a considerable amount of tumor with a large overlay of blood clot over it. And then once I have seen this, I decided to go back, and the patient also agreed. And in the same week, we went again and we managed to remove the tumor in a reasonable manner, though you can see that there is a lot of edema around it. One of the papers which I did not quote is this paper which has been published last year by the Nimhans group, which have talked about more than 100 cases of transcranial surgery and have shown that almost 20 of them developed large postoperative hematomas requiring treatment, and the DI rate was also very, very high. So we are dealing with a tumor which, if not treated properly, has a high degree of mortality and morbidity associated with it, unlike the usual pituitary tumors, which we think are straightforward and should give us very good results. Thereafter, the expansion of the transnasal approach with endoscopy, and we were probably one of the earlier people to start using endoscope for pituitary surgery. We found that results were favorable when compared with traditional microscopic surgery, and similar was experience of several people, which has been published in several papers now. And the intracapsular resection, and as we have seen that the diaphragm gives us a very good kind of a covering to this tumor by an endoscopic method, not only gives us a reasonable resection, but also prevents the complications associated with transcranial approach. Fred Gentili also wrote about this. He has used the criteria of 4 centimeters for his calling them giant tumor, and his resection rate was almost 82% with endoscopic sphenoidal approach. And he has also shown that the results were acceptable. However, I certainly find that it still remains an important and very, very, I would still find this a difficult tumor to deal with. The reasons are that this tumor probably is encircling the artery. As you can see, it is not only encircling the anterior cerebral artery, it is also encircling the left carotid artery. And you can see differential densities within the tumor, which may or may not allow you to suck it out easily. And in this particular tumor, if we have given contrast, you can see a solid contrast enhancement, which always makes you worry, because bleeding during surgery, even though it may not be substantial, it certainly makes it difficult for you to visualize the tumor properly. So in this case, we decided that we are going to try out the transnasal surgery first. And we have done an endoscopic transphenol approach. You can see that the tumor looked quite vascular on this, and it has been vascular, but it has been possible even to suck out this tumor. And it's not as easily sucking out. So I usually don't like to curate the tumor very much, use only the suctions. But in this patient, we need to continuously keep on using curates to loosen the tumor. We do not try to pull at the tumor unless it is loosened out completely, and try to get to this tumor further and further. You can see that we have now opened up into the anterior cranial fossa here. And further tumor coming out, but this part of the tumor seems to be tougher and not sucking out easily at all. And at this stage, I decided that we are going to leave this tumor and probably come back another day for either the endonasal surgery with the hope that the tumor might descend, or go for a transcranial surgery later. However, it did not give us any chance whatsoever. Within 24 hours, this patient developed a clot, and I had to take the patient back to theater with a bifrontal craniotomy. And we just waited after the craniotomy for some time till the patient settled down, and then did a 3rd stage surgery to excise this tumor. One of the important problems which has been mentioned earlier by the AIMS people, and now I think more and more people are talking about it, is the pituitary apoplexy in the residual tumor. So whenever you operate on a giant pituitary tumor, it is extremely important that you achieve optimal excision. What is optimal excision according to me is when you have removed enough tumor that remaining tumor, even if it undergoes apoplexy, will not harm the patient. And it is very difficult to come to this kind of a judgment for at least an initial period. That is what I can say for sure. So we tried to use all kinds of paraphernalia which is available for endonasal surgery and tried to see if we can improve on our results. Navigation and vascular Doppler form two important sort of adjuncts, and we have started using them regularly in our cases. And one of the important things, of course, is to insonate the carotid so that you have got a maximum corridor, and which we try to do right in the beginning of the surgery because we want to have both carotids exposed. This is one of the tumors which is actually going mainly into the anterior cranial fossa. It looks as if the diaphragm is probably intact in some area, but may not be in all the areas, with a small area of degeneration here. So we are doing an extended transphenol approach. This is the level of the anterior clinoid. We have gone beyond that into the anterior cranial fossa, a typical figure of 8 incision. Then you make an incision below and above the anterior intercavernous sinus to get into the anterior cranial fossa, and then you start removing the tumor. You can see that most of the normal pituitary gland is at the back, plastered against the clivus, and therefore our attempt was to remove tumor first of all from cavernous sinus to cavernous sinus laterally. You can actually see the normal pituitary gland lying at the back, and now we are entering into the suprasellar component with the famous diaphragmatic opening which Dr. Atul Goyal showed us a little earlier. And we tried to enlarge this opening so that we could get safely into the intercavernous, anterior cranial fossa. And you can see the nodule going into the anterior fossa over there. We start removing this nodule afterwards. And this certainly becomes easier. We find that with the endoscope, but then a 30-degree scope is being used. You can see both the anterior cerebral arteries, you can see multiple perforators, and you can see the arachnoid areas. You have to use curved suctions to get to this area, but eventually the whole tumor could be slowly removed. You can see multiple arachnoid compartments from where the tumor can be removed without damaging the perforator. If you use graded suction, which is equally important, I think, not only for microsurgery, but also for endoscopic surgery, which is unfortunately being called just a pull and pull surgery. I do not think a gradual pull with a keyhole suction is as important in endoscopic surgery as in microscopic surgery. Then we put back the bone and then we put back the flap. And this patient has had a very good excision, as you can see on the post-operative scan. And this 27-year-old young man actually got married and has a child now about 6 years after his surgery. And you can see most of the pituitary gland is at the back and some of it is splayed onto the diaphragm. And you can see the depression of the pituitary stalk over here. Another giant pituitary tumor which presented with small apoplexy. Patient presented with sudden visual failure. And again, you can see that once you have exposed enough, once the blood clot has come out because of the recent apoplexy, you have a huge amount of space here to get this tumor out slowly. And we have been able to again get this tumor out, and you can see that the normal pituitary gland is preserved over here. Further and further tumor is coming out, and eventually you can start seeing some part of the diaphragm, but we have put fascia, I think, already there, and the CSF leak has been stopped, and then we put some fat here to get out. Post-operatively, we realized that a small portion of the tumor or probably a blood clot is still left behind, and this patient later on was subjected to radiotherapy as there was some growth which was seen. This is another patient, actually was operated earlier, and the tumor, because of its stickiness, could not be removed at another center. And then they asked us if we could operate this patient by a transphenol approach. You can see that the tumor is growing into the ventricle, and this tumor is also possible to try it out if it is not too hard. If it is a hard tumor, then of course it is difficult to gut the tumor, difficult to break the tumor, which is very, very important, as Atul has told us. But the tumor did not look so bad, and we managed to remove this tumor. So sometimes I think an early impression can also be a little bit of a problem, and you need to have proper instruments, and you can see that you can get into the suprasellar space quite nicely. The cavernous sinus and all the sellar tumor has come out, so the wall started closing up. We had to keep them open, and then we have made a small opening into the diaphragm and trying to get around the infundibulum to get the suprasellar tumor out. Eventually flap to stop the CSF leak. And this is the post-operative picture. There was a small element of tumor which has remained here. And this is about 6 years, and this boy has not had any further growth of this lesion. So he is kept under observation. I think what is important is the tumors which have gone into the cavernous sinus. Forget about the lateral margin, but when you have a 270 degrees encircling of the tumor, the lower part of the tumor can sometimes be difficult unless you open the dura over the carotid completely. An endoscopic approach allows you to do that. You can see in this patient, both the clival carotid give you a very good idea about how far you can go, and the bone being removed over the carotid. Now on the right side where the tumor had gone, you can see the carotid is turning inside over here. So once you have opened that, then it becomes much easier for you to remove the tumor. I have suffered once by making a small puncture in the carotid while opening the dura. So I open it inside out now when I am going laterally with a scissors. And we have started removing this tumor. While gutting the tumor, we first try to take the tumor out of the cavernous sinus wall where there is less penetration. And then we go on to the opposite side, at the same time clearing the tumor from the clavus at the back. So you can now see that the whole carotid is skeletonized here, and we have been able to get into the lateral compartment of the carotid here very nicely. So 3B, what is the stage sort of grade called in NOS, which is supposed to be difficult. As Dr. Goyal has shown you, it is probably easier to remove the tumor from the superior wall of cavernous carotid than the inferior wall. But if you have been able to open the lateral to the carotid, you should be able to do it. Normally, you need to do a pterygoid approach to do that. But in a patient where the tumor has actually made space over there, it is possible if you have opened the carotid and if you can retract the carotid a little over there. Anyway, so I think intraoperative guidance has also been quite talked about for doing surgery on giant pituitary tumors, and I think probably it will be important if you decide to go definitely lateral to the carotids. The question about combined approaches I have initially talked about, and we tried to do some cases, but we have not been very happy about doing that. And I should say that this group has talked about preoperative risk factors for postoperative problems, and older age and intraventricular extension have been found to be uniformly bad factors. The question about simultaneous surgery or two-stage surgery, this is one of the earlier papers which prompted us to think about this, and we have done altogether, I think, 3 cases. One of them worked out well, one of them developed infection which took a long time to get treated, and one person actually succumbed to infection. So we have now been taking the approach of doing a stage surgery, and with our experience of some early cases, we have kept transphenol surgery as usually the first stage and transcranial surgery as the second stage. This is a classic example. We've been able to remove the tumor in the midline by transphenol approach, and then for this approach we went by a transcavernous approach and removed this tumor completely, another one of the same type. I think a few things which probably need to be talked about is that the percentage of transcranial surgery has reduced. This was when we had completed about 900 cases. That time our transcranial rate was about 7%, and it has remained under 10% all the way through. I think Dr. Sharma from AIMS has also written about this, and he has also preferred the transphenol approach, like what Dr. Goel has proposed. And I think we all believe that radiation also has effect, a beneficial effect in the tumors where you cannot remove the whole tumor. My most striking case is this 11-year-old kid who came almost blind. I decompressed her, but I could not remove much tumor. It was so hard. And then I subjected her to radiation. This is a 3-year picture, and this is a 10-year follow-up picture. This girl has been virtually cured of this tumor, where 90% of the tumor has been treated with radiation rather than surgery. So important thing is, whenever you are treating giant pituitary tumors, you should find out if it is functioning or non-functioning. What is the status of hypopituitarism apart from visual status, the status of cavernous sinus involvement, paracellular extension and ventricular extension, and these should be documented for considering your own morbidity and your future plans, how you are going to treat these patients. This is a classic example. This patient came to me with one-sided visual failure. On hormonal estimation, we found out that he had prolactin levels which were 3,200. So rather than trying to go into this paracellular tumor, we stabilized his vision with steroids, and you will find that within 9 months, the tumor has virtually disappeared. So I think if a patient does not have too bad a vision, I would still consider, even in a giant tumor with prolactinoma, to treat them medically. The last case I will show is the girl who presented to us with a resistant prolactinoma. This girl was very well treated with prolactin, remained stable for about 1.5 years, and then she represented with not only increase in prolactin but also with visual failure. And here the tumor was going mainly into the ventricle. So this patient has had a small extended approach. You will find that we are opening the dura just like what we did in the earlier case by first coagulating the dura over the anterior intercavernous sinus. The tumor has been suckable. You can actually see that this is a normal pituitary gland, and we could start separating the tumor away from the normal gland, and we could manage to get a plane. And then we have been able to get inside. You can see the undersurface of the optic chiasm, which has been cleared. And then the third ventricular component is being removed with a 30-degree scope and a curved suction, where we have been able to get inside, and we are removing the tumor from the wall of the ventricle. On the top, there is still a blob of tumor. Once that comes out, you will be able to see the nice anatomy of the third ventricle, and in fact, opening into the lateral ventricles through the foramen of Monro, which you can nicely see, and which is one of the biggest advantages of using endoscopy, because you cannot get these kind of angles unless you are Dr. Goel, I suppose, who can bend the microscope in any way he likes to see. So I think what is important is also that these are possibilities. These possibilities certainly exist for radical removal of tumors. You need to remove the tumors radically, because if you leave a large part of the tumor behind, you are likely to get not only residual tumor, but apoplexy in the residual tumor, which, as I showed you, and has happened to us in about 5 or 6 patients, where you had to immediately go back for second surgery. Dr. Geeta Chako, Ari Chako, their team has also shown that many of the tumors which are supposed to be non-functional, in their study they have found that they are also functioning tumors with gonadotropic tumors, and these could be treated even partly medically. So I think you need to see if the patient has a hormonal secreting tumor or not. You need to see its relation with not only the carotid, but also with the other vessels like anterior cerebral or very rarely basilar, as they can involve these. You also need to see the visual status of the patient, obviously, and if their patient has hypopituitarism, and then take your call about removing the tumor. During surgery, the consistency of the tumor definitely matters, but your plan should be to do first what would be able to achieve you maximal excision, and then go for the second stage if you cannot manage to do that by another approach. In our experience, I think we have had trouble with whenever we have used transcranial as the first approach, and therefore our current approach is to treat these tumors transphenolally. And at some stage, if we feel that we cannot remove any further tumor, we may plan second surgery by transcranial approach. Thank you for your patient listening.
Vida, you want to say?
Yes, sir. Thank you, sir, for this fantastic talk and your experience in endoscopic and transcranial pituitary surgeries. And you've highlighted many aspects of pituitary surgery and how to handle them. And sir, should we proceed with the next talk, or?
Yes, with Ipe's lecture.
Ipe, are you ready?
And then I can talk after him, okay?
And then we can have the discussion.
Yes, yes, I'm ready, Abida.
So we welcome the next speaker, Ipe Cherian, who has now recently come back to India. Not recently, now it's nearly a year. And let's hear his views on pituitary tumors. Go ahead, Mike.
Thank you. It's an honor to be part of this trio. I mean, these are people who are giants in terms of pituitary tumors, just not in India, but I would say all over the world. And I was listening to both the talks. Of course, it was very enlightening. And the normal pituitaries, as everybody would know, the so-called normal pituitaries, there are no normal pituitaries actually, but the so-called not so giant, not so invasive tumors are rather straightforward. I mean, they are not difficult, but the difficult ones are when you have giants which are involving the cavernous sinus or which are going suprasellar. Now, how do we go about it? Dr. Pujari has given a beautiful insight into how we go about them. For us, we are in a stage where if we have a big cavernous component, we first go transcranial and only target that part. The cavernous component is the only part we target. So we do a modified Dolan's approach. We go between the optic and between the carotid and the third nerve, between the third nerve and the fourth nerve, between the fourth nerve and the V1. We take out all tumors from anterior to posterior so that the cavernous is completely emptied out. And then we go in with a transnasal approach where we hope to remove the rest. Again, as he clearly told, sometimes it is not easy to resect these tumors. These are very, very difficult tumors. And as Dr. Goel had clearly highlighted, the diaphragm is your limit. I mean, it's your guide. It's your light. Now, we've had cases where people have gone through the diaphragm previously. I mean, in previous surgeries, these are really difficult tumors where, you know, the tumor comes back with vengeance. So it is already, there's a hole in the diaphragm and the tumor has gone into the posterior fossa. So through that hole in the diaphragm and it's encasing the vascula. So sometimes with the endoscope, you have to follow the tumor through that hole in the diaphragm and then try and take out the tumor as much as possible. Again, as much as possible, as much as you can see. So we're going to show you a little bit of anatomy first, and then show you a little bit of how do we go about and remove the cavernous component. Just to orient you as to how the anatomy is, I'm going to show you first the anatomy first, and after that we're going to show you how we go ahead and remove the cavernous part. I'm sharing my screen, and so this is illustrations by Boralax. So we're going to start. So this is the position that we use. You can see this. Can everybody see this, please?
Yes, yes.
Okay. Right. So this is the incision that we use. We do a rather small craniotomy. We just did that a week back or 10 days back, the same thing. We use the sagittal unlocking first. So we drill out the entire sphenoid ridge so that we can get into the skull base and to the cavernous sinus. And after that, we go ahead, once we do the sagittal unlocking, we go ahead and do the axial unlocking. Sagittal unlocking does actually this. So what we're doing is, this is the sagittal unlocking. And then once we have done the sagittal unlocking, we go ahead and do the axial unlocking. That is to take the temporal lobe away from the cavernous sinus. So that is what we do. So here we preserve the true cavernous membrane and just bring out this temporal lobe away from the cavernous sinus. This can be used, so this is how it starts. So the temporal lobe is slowly pulled out from the, slowly dissected away from the cavernous sinus. And the cavernous sinus is uncovered. And there's not much of bleeding because the true cavernous membrane is preserved. So you can see the cranial nerves. Underneath that membrane. That's very important because if you transgress that membrane, you're going to have a bleeding. So once you open that membrane, in a tumor, there's not going to be much bleeding. But if you're going transcavernous, for example, you're going to the posterior fossa or a basilar tip or a superior cerebellar artery, you would want to preserve that membrane. So this would be the anatomy like. So you have the carotid there, you have the PCOM there, you have the basilar P1 there, superior cerebellars there. So this is after axial unlocking. This is the anatomy that you get. So you have the third nerve, fourth nerve, V1, V2, V3, and you have the optic nerve, the carotid. So this is the anatomy that you get after your transcavernous approach. So even when you're doing a cranial or a giant pituitary tumor, this is the anatomy that you would expect to see. Now, I'll go into the dissection part of it. So you have on my bottom right, you have the frontal lobe. You have on my top left, you have the temporal lobe. So this is the orbit. So you can see the orbitomeningeal band there. So I'm just disconnecting the temporal lobe away, dissecting the temporal lobe off away from the cavernous sinus. So that is a superior orbital fissure. That's the orbitomeningeal band. That is the frontal lobe. That is the temporal lobe. So slowly we are dissecting it away and keeping on removing that. Once you remove that orbitomeningeal, cut the orbitomeningeal band and dissect the temporal lobe away, your anterior clinoid process is going to be uncovered. That's a superior orbital fissure there, and that's the cavernous sinus behind it. So once that is a clinoid process which is removed, and once you remove it, you can start seeing the cavernous sinus there, the roof of which that would be the third nerve there, and that would be the fourth nerve, and that would be the V1 going into the superior orbital fissure. So you are removing the optic strut. Obviously, that's not how you remove it in a patient. That is the optic nerve. The carotid is there, and that's the strut. So the strut is usually removed for paraclinoid aneurysms. I use a 1 millimeter drill there. But in a cadaver, generally, we don't have to do that. So that's a carotico-oculomotor membrane. So going behind. And so that those are the windows. So that's a fourth nerve. And that's V1. So between the fourth nerve and the V1 is your Parkinson's triangle. You can dissect it all the way, and you will see the C5 segment of the carotid. This is C5 is a paraclival segment of the carotid. That's a vertical paraclival segment of the carotid. And here anteriorly, it will transform to the C4 segment of the carotid. That is the horizontal intracavernous. And here at the transition point, you will find the meningohypophyseal trunk. And these are that is the fourth nerve. That is the fourth nerve. And between the third nerve and fourth nerve also, you can develop a good window. So between the third and fourth nerve, you can go anterior on the horizontal intracavernous carotid. And between the carotid and the third nerve, you can go onto the above the horizontal intracavernous carotid. That is the roof of that is what Dr. Goyal was saying about the tumor abutting the roof of the cavernous sinus. And this can be got by going between the carotid and the oculomotor nerve. And this is the sixth nerve. You can see that's the sixth nerve. So on the carotid, just medial to V1 is the sixth nerve. So the sixth nerve is, I'm just hooking it out. Obviously, in a case that you don't do that, but here you are hooking. This is the V1. This is the fourth nerve. And in the Parkinson's triangle, I'm hooking out the sixth nerve there. That's a sixth nerve. That's a sixth nerve there. It's going into the Doralose canal there. For a petroclival meningioma, of course, you can go ahead posteriorly and drill the cavasses and cut these ligaments and get into that space. But it's obviously in a pituitary tumor, it's not required. So all this part is not required in a pituitary tumor. So this is a basilar being clipped with the same approach, but let's go into a pituitary tumor now. So we are doing the same approach. Now, this is a frontal lobe, that's a temporal lobe. This tumor has a giant pituitary, giant component in the cavernous region. So we are going and cutting the orbitomeningeal band, removing the clinoid, and we are going ahead and exposing the cavernous sinus. So stitches on the temporal lobe and the frontal lobe, exposing the cavernous sinus, further exposing the cavernous sinus. So that's exposing the cavernous sinus without any bleed actually. So you can see the cavernous sinus completely being exposed and the tumor within the cavernous sinus. So slowly the temporal lobe is pulled back. That's a frontal lobe. That's a temporal lobe being pulled back, and that's a cavernous sinus with which is a yeah. So that's what we are seeing right now. So you can see the temporal lobe being pulled back there, and the frontal lobe also being pulled back. So you can see the cavernous sinus, and we're going to get into the cavernous sinus now. So it's very important to open the cisterns here so that the brain becomes much more lax. Once before pushing this temporal lobe back, you can open the cisterns in the base there. And once you open the cisterns in the base, this brain is going to be very, very lax. And once you do that, then you can see the tumor and the cavernous sinus there. So now we are going to remove the clinoid. So that's a clinoid process. So we outline the clinoid completely under very, very high zoom, and we can just remove it off. And that gives you the window. That's a clinoid window between the carotid and the third nerve. So that is the roof of the cavernous sinus. So that is where the dura is pushed up. And you see the dura pushed up by the tumor, pushing the roof of the cavernous sinus up. This is where you access that roof. So you remove that, and after that, so you can see once you remove that, that's a window between the carotid and the third nerve. So the carotid is here, The third nerve is here. So you open that and then you go into the next window. So that's the third nerve. So you're keeping that membrane over the third nerve intact. So that's a carotid there. So the carotid, between the carotid and the third nerve, the tumor's removed. And then we are going and opening between the fourth nerve and the V1, the third and the fourth nerve. I will show you this. So this is the third nerve. This is the third nerve. So you can always you can open that. You can just pull the dura up, bipolar the dura over the third nerve into the superior orbital fissure, and then cut all the way into the superior orbital fissure. The dura is very vascular there. So you have to kind of hold the tumor up, hold that dura up away from the third nerve, bipolar it, and then cut it all the way into the superior orbital fissure. So this is the window between the carotid and the third nerve, and you can use a hook like that, and then you can open it. You can open using a hook and a scissor, very gently. The whole point is no pressure at all. And I can assure you, in spite of people telling you that these patients develop a lot of cranial nerve palsy, they don't. Generally, they don't. So if the tumors, as Dr. Goyal and Professor Goyal and Professor Deopajari said, it is all about the consistency. If the consistency of tumors such that you have to really push and pull, then it's likely that you may develop your problems with your cranial nerves, but otherwise, no. So you are removing the tumor between the carotid and the third nerve. Now you are in the window between the third and the fourth, and you are dissecting all the tumor away from the third nerve now. They are now opening between the third and the fourth nerve. You can see the membrane over the fourth nerve being kept. So that's the fourth nerve. So you can see the fourth nerve clearly. That's the fourth nerve. That is the fourth nerve. That's the fourth nerve. So this is the window between the third and the fourth. So you are going, so that is a window between the carotid and the third, and this is the window between the third and the fourth. And you're opening the window between the third and the fourth, and you're taking out all the tumor from between the third and the fourth. You're going underneath and displacing all the tumor from, and you must understand the C5 carotid is going to be there, so you have to be very, very gentle. And over the sixth, you have the infralateral trunk. So that the sixth will come there, and the infralateral trunk will come there. So you got to be very careful. You don't want to tear the infralateral trunk and create a hole in the carotid. Can be managed, but it's a bit of an issue there. I mean, you really don't, because when you're managing that, you are going to put a lot of pressure on these cranial nerves. And you can obviously manage that hole in the carotid. If you have a hole in the carotid by tearing the infralateral trunk, you can manage it. I mean, you just need to put a muscle patch down there. But then you are likely to have a lot of cranial nerve palsies there. You really don't want to do that. So that is the window between the third and the fourth. So this is what we did last week, and then we went ahead and after that we had cleared all the tumor in the cavernous sinus, and then we went ahead with the endonasal approach to clear the rest of the tumor. So we had some very little residual tumor on the part above the MCA, but it's such a large tumor, twice operated and recurrent, and we had to go back. We had a hole in the diaphragm. We realized that there was a hole in the diaphragm, and it was leading to the CP angle. So we went ahead and excised that tumor as well. So it was abutting the basilar, so we could take that out as well. But these are really these are really challenges, and these are not easy tumors. These are very, very difficult tumors. So I would ask Professor Goyal to come back again, and then we will discuss some questions, as well as if somebody has questions and somebody has any points to discuss as well, we can discuss that. And I'll ask Professor Goyal to come ahead and comment.
Okay, that was a wonderful presentation by you and a wonderful case. So what I'm going to do is I'm going to show you some historical perspectives rather than, you know, there is some noise. Okay. So now here I continue with my lecture. Now this tumor I had operated about 20 years ago. And you can imagine there is a very small cellular component and a large supracellular component, but my concept of dura was there. And I did this small incision here and broke the tumor, broke the tumor, broke the tumor, broke the tumor, broke the tumor till the entire diaphragm came into picture. And you see, this is the post-operative image. More important than anything else is that these patients who come with visual deficit immediately after surgery recover in vision. Now just hold on for 1 second, please. Sorry for that interruption again. Now, this tumor are benign tumors. These tumors, you remove them, the person improves in the vision in the evening of operation. You go and ask him, how are you? And he says, fantastic, doctor, I'm okay, and my vision is okay, and who are you? And you are you. You are beautiful. You know, that result orientation, result-oriented surgery, no other surgery can give you such fascinating results. So my concept is that this is the dura or a uterus, which is the strongest muscle of the body. Do you know that uterus is the strongest muscle of the body? It has the potential to push the baby down. No other muscle is as strong as uterus. No other animal in the world is delivered by trans-caesarean section. All the animals deliver by virtue of vaginal delivery. Only, have you heard an elephant being delivered by a cesarean section or a horse being delivered? It is only a fascination or, you know, a unique human style to deliver by cesarean section. Otherwise, uterus is the most beautiful organ to deliver the baby and natural. Similarly, in pituitary tumors, this diaphragm cell is a beautiful organ, divine organ in my estimation. The tumors, you see, many are soft and cystic and breakable. You, as I mentioned to you, learn the art of breaking the tumor. You just have to remove the anterior wall of the cella, break into the tumor, and the diaphragm cell should pump inside your surgical field. There is no need to remove planum sphenoidale or tuberculum. You don't need to look like this. You need to look straight and the tumor will fall straight down. That is the beauty of this tumor. This is another tumor operated, I think, 25 years ago. And the concept was cella, concept was dura of the diaphragm, break into the cella and demolish the tumor, and this will be the outcome. So I'm going to show you several of these tumors. Many of them are 15 years, 20 years old cases. And what you have to imagine is that the concept of dura has been in my mind for so many years. I have published it for so many years, and how strong that concept has been with me for so many years. You see, this is the tumor, small exposure, and this is postoperative fat. And I must say nowadays, my introduction of fat in the postoperative cavity, my introduction is much more than what I used to do earlier. What my earlier recommendation was, when the diaphragm was intact, there is no need to introduce fat also into the surgical field postoperatively. The diaphragm covers the whole area. But nowadays, my introduction of fat is a little bit more. Even if I see slightest amount of CSF in the surgical field, fat will come into picture. So let me show you some of these cases. You see large extension into the sphenoid sinus. Dura is covering, bone is covering, enter the dura, demolish the tumor, That art how to demolish has to be learned. That art how to break into pituitary tumor has to be learned. Now about the cavernous sinus portion of the tumor, what to do in non-functioning tumors is a controversial issue, whether you have to remove the part in the cavernous sinus or not, because these patients come with visual deficit. You remove this tumor under the diaphragm and the vision recovers. Whether you need to remove this tumor and subject the patient to the risk of extraocular movement discoveries is an issue which has been discussed for several decades, but the answer, I believe, is not yet clear. My strategy in non-functioning tumor is resect. By virtue of the consistency of the tumor, you can go inside the cavernous sinus and remove as much as safely possible from a nasal route. Now you see this tumor, which was uniformly removed by transcranial route 25 years ago. Many of you are young neurosurgeons in the audience. You may not even know that these kind of tumors were 100% times removed by a transcranial route. But this anatomical fact of diaphragm has enabled me to remove this tumor in a very effective and quick fashion. Now this is, I call a pregnant tumor, large belly, small head. You remove this tumor, the part in the belly and the head will fall down very instantly and quickly and beautifully. This is another pregnant tumor, belly large. These are beautiful tumors to remove. I must say, and there's no exaggeration to say that these tumors I will remove in 10 minutes or 15 minutes. And there is no hyperbolic about this, because these tumors are soft. You break into the tumor and they will rapidly decline or get into the surgical field quickly as you can never even imagine. And more importantly, you remove them beautifully, the results are tremendous. So there are controversies whether you use endoscope or microscope. Those are very flimsy controversies. Basically, the controversy should be whether dura is there or not, whether they are subarachnoid or not. But if your concept is that dura is there, the controversy does not remain. Now, another slide which I have got specially now after the lecture of Dr. Dev Pujari, and he must refer to this slide. Fatal postoperative pituitary apoplexy was first published by me in 1995. And this was the first article which said that if you remove the tumor partially, there is a possibility of apoplexy in the residual tumor. So it is that it does not happen always, but sometimes it can happen. So you have to remove these tumors radically. Now you see this tumor, I removed it 23 years ago. And you can imagine this tumor going like this and going up, and the concept that you can remove this part of the tumor by remaining transnasal was a great concept 23 years ago, you can imagine. And this patient, I lost the follow-up, but this patient was doing well few years ago. So these tumors are benign. Radical resection is wrought with fantastic result in the year 2000, 21 years ago. This is postoperative scan showing tumor resection. These arteries are not in the tumor. They are under the dome of there is a dura which separates. There is a dura which separates this artery. You see, this artery will never be seen here, except in grade 4 tumors. So this was removed several years ago in a beautiful fashion. This is not artery. This can never be artery. This is some necrosis or some bleeding within the tumor. And if this is an artery, you cannot remove from the nose, because you cannot dissect the arteries and perforators and all those things from a nasal perspective. But you have this concept of dura and you remove it beautifully. This is another tumor with a huge extension. This is postoperative image. This is another tumor. I said these nubbins are not, this tumor does not go intradural. This is immediate postoperative scan. You see my picture is just anterior wall of the cell, no tuberculum cell. You don't have to look like this straight. You have to look like this and you can remove this tumor. This is of course quite a straightforward tumor for a person who is going to do this kind of tumor. There can be no tumor simpler than this. There is some blood and you can remove this tumor with very fascinating clinical outcome. This is smaller cella, bigger head. Remove the anterior wall, necrosis. Those who are having big heads are usually soft in nature. Those people are big-headed externally, but they are soft inside, mild inside. You break into their softness and they will bow down quickly into your surgical field. You see this tumor, which is quite a tumor. I did it several years ago, and this was the post-operative outcome by just removing. So the concept of diaphragm is absolutely magical. And you have to have this concept if you have to remove these kind of beautiful tumors. Now, this is another tumor, and this is another tumor. You see, it looks like going into the brainstem here, but there is dura and diaphragm, and this was removed completely, beautifully, and fantastically. You see, this is another tumor, and this is post-operative, some residue. This is another tumor which is going. So the purpose of my presentation is just to give you a concept. And these tumors, you see, as I have mentioned, can be done in quick time. This is immediate post-operative, some blood in the area, but which will eventually resolve. Now, this blood will also be protected by the diaphragm. It cannot go inside the brains. So you preserve the diaphragm, you protect the diaphragm, and you create a person with benign tumor and you give him a new life. In my surgical strategy, there is no bipolar does not come into my surgical field. For several of my cases, never bipolar cautery has come. Only break the tumor, break the tumor, break the tumor, and you will find the whole tumor. Put gel foam, wait for some time, everything will stop in no time. So this is the diaphragm, this is the diaphragm, this is. Just enjoy some of these beautiful cases, which are not easy in a common parlance, but they are doable and quite. Now, this tumor I had done in the year 2001, just small exposure here. You can see there was some residual tumor here. In 2007, this tumor has grown in size. So my concept now is usually, even if there is a residual pituitary tumor, I don't like to give radiation. But if the tumor is more than 5 centimeters in dimension, in any dimension, and there is residue, I like to give radiation for these kind of patients. This is another tumor I did in the year 2001. You can imagine, you see this kind of tumor. Even today, people will hesitate doing it from the nose. Most of the people, if not all the people in the world, will like to do transcranial route. You see, I have done transnasal route in the year 2001, 20 years ago, and I removed this tumor, and this patient was lost to follow-up, and this patient came back in 2008 with a recurrent tumor. So now my strategy is tumors which are more than 6 centimeters. Even if I've removed the tumor radically, I like to give radiation, even if there is no residual tumor. So this is another beautiful tumor. You just enjoy the preoperative and postoperative whilst the patient is enjoying the vision. Now, this was one tumor which I did transcranial. And you can imagine transcranial surgery very rarely. You see, I don't remember this case, but this was done transcranial some maybe few years ago. But I rarely do transcranial, but in some of these more intimidating problems, transcranial route may be possible and necessary. So what about cavernous sinus invasion? My surgical strategy is for tumors which are functionally active, you have to remove the cavernous sinus portion. I like to do it from the nasal portion, from the nasal route, respecting the dura here, sixth nerve, and all those things. Basically, the tumor consistency will guide you to the operation. You have to know where the carotid artery is, how the carotid artery has to be handled, and how the tumor has to be removed. And these are, these are issues of cavernous sinus is a completely different subject in the parlance of pituitary tumor. So whether to remove this tumor, bilateral cavernous sinus invasion, you see how the tumor has been removed. This is another tumor. I'm not sure if I did transcranial route for this tumor, but there was residue, and I might have done transcranial for this huge residue of the tumor. This is another quite a intimidating tumor. But you remove the tumor, you have the capability of the tumor, you have the potential of breaking, you have the art of breaking these tumors, you give new life. Basically, what I want to emphasize is you have to have that art, and you have to have that concept, and you have to have that vision to be able to give vision back to the patient. You see this another beautiful tumor, and this part of the tumor was difficult to resect. I'm not sure whether this part is blurred or whether this is tumor, but usually I will not leave tumor behind because I will like to see the dura here. And if I have left some tumor behind, then I'm not sure what is to be done, because if the vision has recovered, I like to wait and hold on, because this part of the tumor will need a separate operation, if at all. So this is another elevation of roof of cavernous sinus, part of the tumor in the cavernous sinus with elevation. These are more aggressive form of tumor. And you must remember that this residual tumor is not like a residual tumor otherwise. This tumor will need radiation treatment because the propensity of recurrence is very high in these tumors. This is another non-functioning tumor. There is bilateral, several years ago I had done, and there is no growth on this tumor. I have not given radiation. Whether these will require radiation, whether should have been given, should not have been given, is a questionable. Some tumors recur, some tumors do not recur. This is another tumor I had done several years ago. Elevation of the roof of cavernous sinus dura, and I had left this roof, this part of the tumor behind. And I did not give radiation treatment, and this part of the tumor had recurred. I will show you the image in my next picture. You see this case, I had not removed this part of the tumor. There is residue here in the cavernous sinus and the roof, and there is recurrence 6 years later in the roof of cavernous sinus. So nowadays my policy is whenever there is cavernous sinus invasion and elevation of roof, I like to give radiation treatment up front. This is another tumor, you see, beautifully resected. Just enjoy the images and you enjoy the beauty of these tumor resection. And I am telling you, this kind of nubbins that you are seeing are part of the dura. Dura is covering, and you can get that nubbin into picture of the surgical field. This is the elevation of the roof of diaphragm cell, roof of the cavernous sinus. I removed the roof of the cavernous sinus, removed several years ago. And this patient, I'm not sure what is happening to this gentleman, but must be fine, because these tumors, but the tumors which elevate the roof of cavernous sinus, as I mentioned to you, are inherently more aggressive in nature. So this is the part, this is blood in the cavernous sinus roof and in the under the diaphragm. This is many of these patients. I'm showing you immediate postoperative pictures, but because in the setting which I work, many of these patients are from villages, from smallish towns, and potential for coming back for follow-up and re-imaging becomes a difficult issue in many of my patients. So there is residue in the cavernous sinus just left behind. There is residue in the cavernous sinus left behind, whether to give radiation or not. This patient, I gave radiation, and the tumor disappeared after radiation. But this patient had severe convulsions for several years, and I am blaming the radiation for convulsions. I am not sure whether it is radiation, but this patient ultimately died in following one of the convulsive episodes. This patient, I did transcranial route to remove this tumor in the cavernous sinus, because the cavernous sinus portion was definitely much bigger than the cellar portion. And this is the postoperative images. This is another tumor residue in the cavernous sinus. This will need radiation. My feeling is to remove this part of the tumor which elevates the roof of cavernous sinus is a little bit tricky, because the third nerve relationship becomes a little bit tricky to handle. So this is another tumor with residue in the region of cavernous sinus and the roof. This is another huge tumor. You see the midline tumor is removed. Now this portion, will need transcranial surgery for resection. This is the tumor with bilateral elevation of roof of cavernous sinus. So this tumor, both elevations were left behind. Just the midline portion was removed. And then I gave radiation. You see the elevations have reduced in size, and the patient has been all right for several years. This is after several years, the imaging. So this is also a postoperative image. Now, grade 4 tumors are those which encircle the arteries of circle of Willis, and these tumors should not be removed aggressively. And there, if you remove aggressively, you are putting the patient in high danger. My recent concept is tumors with grade 4 tumors, like I am mentioning, are hormonally active, and you should consider giving treatment by drugs like bromocriptine and things like that. This tumor, which is encasing the artery, you will encase the perforators and can put the patient in great danger. So this tumor I had treated with cabergoline, and you see, then I treated with surgery. So combined surgery and cabergoline. This result is here in front of you. This patient was treated with only cabergoline and no surgery was done. This is another high prolactin tumor, which was treated by only drugs. And you see, so these grade 4 tumors are more beautifully treated by drugs. So this is the concept which I am trying to develop. Now, what are my danger issues in large or giant tumors, which are very big, more than 5 centimeters is a danger issue. Higher grade tumor is a danger issue. When patient comes to you drowsy, it is a danger issue. When the patient comes with altered behavior, it is a danger issue. You can kill the person. When the patient has hypothalamic dysfunction, it is a hugely dangerous issue, and you can have death on your table. When radiation treatment, grade 4 tumors, I give radiation treatment. Grade 3 tumors, when there is a significant residue, I give radiation treatment. When grade 1 tumor is more than 5 centimeters and then there is a residue, I like to give radiation treatment. And recurrent tumor after surgery may be radiation treatment. So this is my concept. Now recently we did a proteomic studies of various grades, and you can see some of my papers on this subject. Now I want to quickly show you some images of cysts within the tumor. Many of these tumors have cysts or necrosis or bleeding. Now let me show you some beautiful images, just images, no discussion, no talking, okay? There can be a fluid level in the tumor. There is a fluid level, beautiful fluid level. The large tumors can have multiple fluid levels. You see fluid levels within. So there are various tumors which can have fluid levels. And this was my beautiful article, which was published 11 years ago. Now you see this tumor having a fluid level inside the tumor. This is a very characteristic of pituitary tumor. Tumor having multiple fluid levels. You see fluid level, fluid level. This is a huge tumor, and if you see all the cysts, there is fluid level in every cyst. I will show you, I will discuss with you the implications of this. There is a fluid level in this tumor. There is fluid level in multiple cysts in this tumor. Now you see this, there is a fluid level here, fluid level here. There is a fluid level in this tumor. You see, this is another tumor having fluid level, fluid level, fluid level, fluid level. So this is a very common imaging feature in largish pituitary tumor. There is a fluid level in this pituitary tumor. There is a fluid level which is dividing the tumor into distinct 2 parts. So this is a tumor which is having a fluid level here in the part which is inside the roof of the cavernous sinus, and which is a part which is going behind into the brainstem. But you must remember, even if there is a fluid level, the tumors will respect the dura and the diaphragm and the roof of cavernous sinus. That is very important. Now you see there is a fluid level here, fluid level here. There is fluid level in this tumor, a beautiful fluid level. You see this massive tumor, and you see multiple fluid levels within each of these cysts. You see multiple fluid levels in each of these cysts. There is a fluid level in the cyst. This is a huge tumor. There are fluid levels within every cyst. If you carefully see, every cyst has a fluid level. You see this tumor having fluid level in the cyst. Now I want to, before I go further, I want to say, if you remove this tumor, the fluid will be of hemorrhagic, darkish red color, and you can remove this tumor very easily. But the problem is these tumors will recur. very rapidly. The problem is when it recurs, even the recurrence will have a fluid level. So that is the beauty of this recurrence. You see, there is a fluid level in this tumor. There is fluid level in the cavernous sinus portion and in the cellar portion. There is a fluid level in the cellar portion. This tumor, I call it a beauty queen. You see, beauty, that divides the cellar and the tumor into two components. The whole thing is cyst, whole thing is liquid. The wall of the tumor contains reddish colored tumor, which you have to remove. This is a more aggressive. This is, you see the tumor having multiple cysts, this tumor having multiple cysts, this tumor having beautiful, you see this tumor is having a fluid level, easy to remove fluid level in both these components. This tumor elevation of roof of cavernous sinus, fluid levels in both, and you have removed this. They will respect the dura. This is, I have already shown, this is a large tumor with a fluid level. These are very straightforward tumors to remove, but the chances of recurrence is very high in these tumors. Some of them. So I have talked about benign tumors like schwannomas with fluid level, pituitary tumors with trigeminal with fluid level. The problem in tumors with fluid level is they are due to the tumor consistency, their tumor character. The tumor is fluid, it releases fluid which settles down and makes a fluid level. That is one concept. Second thing is there can be bleeding and that blood settles down. So the tumors with fluid levels are more aggressive in histology. The chances of recurrence is high, and you should give upfront radiation in these tumors. So thank you very much, my dear friends. And I will now like to take the discussion further with Dr. Dev Pujari. Shekhar.
Atul, we have Ibrahim with us. We have Victor. I think let us hear from them. I have heard your views before and I have heard them again. And I agree with a lot of points which you are making, especially for, I think we have been a little hesitant in radiating our patients, but I think some of these aggressive tumors probably should be radiated upfront. I have usually waited till we have to consider second surgery, but I am also changing my approach, especially to this large tumors. And as I told you that if I'm planning two-stage surgery, I'm preferring to do transphenol surgery first rather than doing transcranial surgery first. These are the two major changes that have come in my approach, apart from being more aggressive, and endoscopy has helped me to be more aggressive.
So let us have the views of Victor. Victor, you are there?
Ibrahim has raised his hand, so
okay,
let him
Ibrahim.
speak first.
Okay.
First of all, it's very nice to see you all. So John, Ip, Atul, Chandra, and Derabida, I say to you, Happy New Year. I hope this year is going to be prosperous, full of good things for you all. Thank you for bringing this topic for discussion in this meeting. Giant pituitary adenomas are mishandled everywhere, and giant in India, like in this part of the world, the Middle East, is the norm. It is not the exception. We see giant ones all the time. Giant pituitary adenomas, craniopharyngiomas, everything. So thank you for bringing this up, because the general practice in this part of the world is to take a small piece of this giant adenoma and then send for radiotherapy. The same bad management of gliomas, the same bad management of craniopharyngiomas. So we have to unite and fight this attitude of just a biopsy and then giving radiotherapy. The second point I want to make is giant does not mean invasive. Giant is giant in size, but invasiveness has certain rules. And those rules are that we see invasion on radiology, we see invasion during surgery, and we see the histology. We see invasion of the dura, invasion of the sinuses, of the mucosa of the sinus. And most importantly is the Ki-67 index, which gives you the clue. The other point I want to mention is that for giant ones, I really love to do it transbasal interhemispheric, because this way I can see the inside aspect of both optic nerves, the underbelly of the chiasm. I can go to the right, I can go to the left. I even removed and retrieved tumors from that approach, even from the occipital lobe. You just pull nicely, and as Atul said, they are suckable and easy to remove. The last question is about, or last note about the radiotherapy. I don't jump on radiotherapy immediately for all these giant tumors, but I wait on them, and if there is any sign of any recurrence, I would go for radiotherapy. But some of those cases where they invaded outside the diaphragma, they are surely malignant, and you give radiotherapy upfront. So again, thank you for meeting you, this meeting of the first meeting of this year. I hope you a good time. Thank you very much.
Thank you, Ibrahim, for your comments. I know your experience in giant pituitary tumors. I've heard you, and I am not sure. You said that giant pituitary tumors are more common in our region. I'm not sure if they are not common in other parts of the world, maybe, but I don't, as you rightly said, I don't hear many big presentations of giant pituitary tumors from North America or from Western. I have actually never heard. Maybe you are correct that these tumors are more common in this part of the world, because we see very frequently these kind of large tumors, which assume maybe it is due to the fact that many of our patients do not recognize worsening vision for a long time, and the tumor goes on increasing vision worsening, and these people are just running around without having a consultation with doctors. That may be one reason. But you are right that not many people from Western countries talk about large and giant pituitary tumors. Victor?
Yes, dear. Hello, Dr. Atul Gol. Congratulations for these spectacular lectures, Dr. Depujari, Atul Gol, and also my friend Aib Sherian. So I agree with Dr. Ibrahim. Invasive is not the same that a giant tumor. Most of them are not invasive. So I heard that Dr. Ibrahim preferred to resect these tumors interhemispheric or also occipital, but sometimes it's difficult to work near the anterior communicating artery, also because this artery has so many variants. Some of them help you to resect this tumor, but another variations not, especially because of the small branches that are coming from this anterior communicating artery. I heard a brain surgeon from Germany that he used to divide the anterior communicating artery to resect this kind of tumors. Have you done this kind of tumor? Have you done this kind of approach? And another question, this is the first question, and another question is, which criteria do you use to resect the tumor, either transcranial or transsphenoidal, especially giant adenomas? Thank you so much for these fantastic lectures.
Basically, if you are asking me, Victor, I will say that transcranial surgery is relatively uncommon in my, I rarely do transcranial, but tumors which are really big and you are thinking you may not be able to remove it from the nose, then you might select transcranial. That is one indication. Second thing is when there is a recurrence of the tumor and a large tumor, recurrent tumor to come from the nose and to do radical resection, which is going quite high in the cranial, may sometimes you require a transcranial route. And also, I will say transcranial route for tumors which are, functionally active and you are not able to remove it from the nose, all tumors I will first like to remove from the nose. Functioning tumors like for Cushing disease, when the tumor is going in the cavernous sinus, I will try to go and try to remove from the nose. More the experience you have, more the radical resection you can do from the cavernous sinus. But if there is a residue in the cavernous sinus and you are not able to remove from the nose, there might just be an indication of transcranial root, or you can consider radiation treatment in those cases, which is also effective. You see, the thing is, radiation can be used as a beautiful tool for residual tumor, even in functioning tumors in the cavernous sinus. So transcranial root has limited indication in my perspective, but I still use on some select occasions where I find that it may just not be possible from the nose, and I do. The other question that you are asking is very interesting and important about sectioning of the anterior communicating artery. You know, Victor, this sectioning of the anterior communicating artery, sectioning of the posterior communicating artery has been identified by various senior neurosurgeons in the history of neurosurgery, and they have used it. And many of them have said that it may be safely done. Like you clip the anterior communicating artery and you get a wider field, you can have a wider resection, you can dissect the arteries away and you can do wider resection. You do posterior communicating artery sectioning, you can have a wider resection. But I have to tell you, if you are asking me, I will never do it. And I have never done sectioning of the artery because the outcome I feel can be, unpredictable. You section the acom and you do complete tumor resection and you find a big infarct. Similar is my strategy for superior sagittal sectioning. Many of the people have said that you can section the superior sagittal sinus and then you can go for basal meningiomas and things like that. I will never do this kind of sectioning. I will go from one side of the sinus, from the other side of the sinus, and remove the tumor. I do not like this kind of sectioning of normal vascular channels, and I will like to have the opinion of others. Shekhar, if you want to comment on this, because this is a very important subject.
I agree with your views on sacrificing anterior communicating artery. I would avoid it as far as possible. About what Ibrahim said about the transbasal approach, as I showed you, I did that approach for a while when I thought I will not be able to do a good job transphenol approach. But I think it is hardly ever necessary for pituitary tumor unless you find that there is no other approach available to you for some reason. I would not recommend it as an upfront first choice approach in my experience. We also have Professor Luis Burba with us. Would you like to say something, Dr. Burba, on this?
Hello, good morning.
Good morning, good evening.
Good morning,
I was
Louis.
just trying to, I was enjoying the Dr. Professor Shirin and Goel presentation, wonderful presentation. I agree 90% of Professor Goel said. See, you never know. You never know how much you can remove by transphenol. You never know. Sometimes you think that you cannot reach, oh, the tumor is too big, but you go just, how you say, broken the tumor, go inside the tumor, and the tumor start to come. You remove more than you really imagine by transphenol approach. In 90% of the case of pituitary tumor, I start by transphenol, see, and try to remove the maximum that I can. If you remain a small piece of tumor in the angle or in the cavernous sinus sometimes, in non-function pituitary, I prefer to wait and see, because sometimes the tumor is growing so slowly. See, they don't need radiation. All the time they start to grow again to inside the cellar, you can go again through the nose and clean the tumor wall. When the patient has no pituitary function, see, maybe you can use the idea to send radiation in advance. More you follow this tumor, this large tumor, more you see that there is remaining small tumors. In the follow-up, in the MRI, you see a small piece, but does not mean that you need to do the treatment. What you are seeing here a lot in Brazil now, you used to have tumor as large as you have in India, you have in Middle East, you used to have big, large tumor. But now you are seeing the endocrinology team, they improve a lot. Now there is the neuroendocrinologist, the guy that's working just with neuroendocrinology, and this concept is improving the endocrinology care, but also the diagnosis. See, today is very rare. You see a large acromegaly tumor from acromegaly, see? GH tumor, it's very rare. They do the diagnosis much precoce that they used to do in the past. And then the last thing I want to say that there are so many endoscopy, so much endoscopy, but I'm still doing microsurgery. I learned to do microsurgery. I feel more comfortable doing my microsurgery. The people say, oh, maybe you're an old guy. I use the microscope in the end. I put the endoscope in the C in the corner. Sometimes there is a small tumor that is high in the corner that you cannot see. You go there and remove with endoscope. I think if you learn how to do the correct way with one technique, use. If there is a new technique that's coming, use. But does not mean that just because you have a new tool, everything you are doing in the past is bad. It's not like this. Life's not like this. The experience makes us doing more and more. I have a paper that was published in the whole comparison microsurgery and endoscopic surgery for straight small pituitary adenoma. What is minimally invasive? Put the endoscope in by nostril, take the mucosa, inside in the cellar, take a small tumor, or go straight with the speculum directly in the sinus, open the sinus, open the cellar, and go home without pack, without anything. What's minimally invasive? This you need to ask. In the future, we need to see balance. Balance is everything in life, is everything in neurosurgery. Professor Goyo, I enjoy very much your breaking the tumor, breaking. This is the great idea. Thank you. Bye.
Thank you, Luis. Thank you. How is Brazil? How is the
Good.
COVID situation?
No. In
You
Brazil, you
want to
have
break the COVID. Break the COVID.
Yeah, you have almost 90% of the population is vaccinated. See?
Okay.
Now you have some case in the last week, a number, but very, very light, very light. Nobody in the hospital. But if you go in the pharmacy and do the test, some patient, the people asymptomatic is getting COVID, but completely asymptomatic. It's crazy. I'm afraid to go to the pharmacy, somebody test me to find something.
Okay, now Ipe,
In
you want
March
to
will
make
be
some
break.
Ipe, you want to make some comments?
Yeah, hey, Louis, good friend. Good to see you. And we hope that this Omicron doesn't prevent us from coming into Rio. I would rather prefer Oh My Baby in Rio than this Omicron for sure. So, Victor asked about this in the hemispheric approach. I do not recommend this because as Louis said, I would rather go and do endoscopic because, see, the thing is, the cellar the diaphragm is dura. When you're going transcranial, you cannot remove that dura. It's just impossible to remove that dura. If you remove that dura, you're going to create damage. So the thing that you need to do is you need to make multiple windows. I've seen some guys completely removing that dura. It's morbid. It's going to create problems. So that is why endoscopic scores over transcranial. But the cavernous sinus, and as Louis clearly mentioned, that angle is somewhere that is very difficult to reach with the endoscopy unless you cut above and reach. Even if you reach above, it's very difficult to reach that angle. So that's the thing. That's the only place. I mean, cavernous sinus, yes, you could open lateral to the carotid. Dr. Dipujari was showing, we also do that. We, this time for the GH adenoma, we, in the endoscopic approach, we open lateral to the carotid. And then we could go medial to the cranial nerves, but then that's an end-down view. You're not really in control there. The infralateral trunk is not really amenable. You can create, and if you create a tear with the infralateral trunk with endoscopy, it's much more difficult to control it rather than on an open approach. Believe me, it's hell. You have to back and come out, and you're going to create mobility. So for the cavernous approach, it's completely cavernous tumor. It's always better to go lateral to the cavernous. You can go in between. You have multiple beautiful corridors. You can go take it out and then come back. The rest of the thing, I wouldn't really recommend transcranial. I would always go endoscopic. And with the diaphragm as your guide, you can take out almost everything.
Okay. So any other comment from the panelists or from anybody else?
Lida can summarize or give her comments, I think.
Abida, you are there? Yeah.
Yes, I'm here. So that was a wonderful discussion on pituitary tumors, where we saw the concepts of pituitary tumor surgery, the nuances of pituitary tumor surgery, wonderful dissections by Ipe, and wonderful philosophy by Professor Goel, and wonderful approaches by Professor Dev Pujari. And we have discussed most of the varied strategies in handling them and how to handle functioning and non-functioning tumors. And I think we've gotten a very good overview on this subject. Does anyone have any questions left?
Nothing more in the chat box. I think most questions are answered.
Okay, so then if there is nothing left, we can end this session, and we will have the next session in the next 15 days. The topic will be announced by John very shortly. Thank you very much for your participation.
Thank you very much, and
thanks.
Best wishes for all of you from Mexico. Hello, Luis Burba. Nice to see you here. Bye bye.
Thank you, Luis. Okay. Thank you, Victor.
Thank you, Professor.
Thank you.
Thank you,
Professor.
Thank you, John.
Thanks.
Yeah, it's a great webcast.
Thank you, John.
I'm going to put a link in the chat for the Zoom lounge. If anybody wants to come to interact with other people from this conference, you're welcome to come in. So just hang on a second. I'm getting the link now. It's kind of like a place to interact with the speakers and whoever else wants to come in. The students like it. Okay, I can't generate it. How am I going to do this? I don't want to start the webinar. Okay, hold on. I got it.
Take up next topic as anterocranial fossa meningiomas.
Okay, I'm putting the link in the chat right now. Just copy that link. And once I end this webcast, go to that link. Copy that link, okay?
Okay.
Anybody that wants to come in, the students will love it. We'll love meeting you guys. So I hope you can come in. So copy that, and anyone's welcome. This is not public, it's private, and it will not be televised, it will not be recorded.
So okay. This we have to leave this one, right?
Yeah, after I end it in a few seconds, just go to that Zoom, okay?
Okay.
Okay.
Okay, we'll see everyone there, hopefully.